So the action step is give a tube of blood, get your lipoprotein A checked, okay? All right. Let's talk about the optimism of the war on heart disease, that heart disease is reversible. We may not be able to get the calcification out yet. And I'll just tell you a recent study with vitamin K2 at very high doses failed to show that it takes the calcification out of the arteries. It also didn't take the soft plaque out of the arteries. So vitamin K2 has gone down on my list of agents to use in heart patients. There may be a reason to use a high dose of a special vitamin K2 called MK4 for bone health, but not for heart health. But I want to take you through a little path of history. I already mentioned Mason-Sones in 1958. Now we got to go back even a little earlier. And the gentleman to the left holding, it looks like a notepad, wearing glasses, is Dr. Ansel Keys. He had 2 PhDs. He was a professor at University of Minnesota. And he was interested in the question in the 1940s and 50s, why are there so many heart attacks in Minneapolis that we didn't see 10 and 20 years ago? He suspected it was changes in diet in the American culture. And he went to his friends across the United States, Japan, Italy, Croatia, and other places, and said, let's do a study and look at, is there a factor in the diet? So this is a little town in Italy where they were meeting to plan a serious research study that started in 1958. And they ended up following patients for 25 years, and they knew what they ate, they knew their blood levels, they knew what was in the food they ate, they knew about smoking, blood pressure. This is all before computers. A very difficult study, very funded on a shoestring, but meaningful. It's called the 7-country study. And what they showed in this case is the higher the saturated fat intake in the diet, the higher the death rate of heart disease over 25 years. So if you look in the upper right E, that's a country with a very high saturated fat intake and a very high heart disease risk. That happened to be Finland. And you look way down to the lower left, T, that's Japan. Very low saturated fat intake in the 1960s and 70s. Things change when Kentucky Fried Chicken shows up, and a very low heart disease risk. And when they looked at cholesterol levels and mortality over 25 years, countries with a very high cholesterol in the upper right, Northern Europe would be Finland, had very high cholesterol levels and very high heart disease risk. And when you look way down to the left, Serbia and Japan and others, average cholesterol in the blood of these people, 126 total cholesterol. That's not on drugs. That's because their diet was so different than Finland, for example. It was so low in saturated fat. And they proved it wasn't really dietary cholesterol. It was dietary saturated fat. The stuff you find in whole milk, cheese, egg yolk, red meat, white meat, fish meat, coconut oil, palm oil, although none of these cultures used a lot of coconut oil or palm oil. That's why you hear the guidelines you hear about all the time. One of the most interesting projects was Finland. They were dying in Finland in the late 60s. Men were dying in their 40s all over the place. Serious and true statement. And a region near Russia in Finland called North Karelia got together a program headed up by a young physician whose name is at the bottom of the slide, Pekka Puska, great name. And they taught the public. They changed grocery stores. They changed recipes to lower the saturated fat in the diet. Less sausage, less cheese, more vegetables, more beans. And the heart disease rate dropped like crazy, 80 to 85%. So they extended the experiment all across Finland. And they found the same thing. But what they found was when they lowered the saturated fat rate, this is the data on the right, not only did all cases of death go down over the course of 20 years, not only did heart disease deaths go down over the course of 20 years, but even cancer deaths went down. So people were eating less animal foods and more plant foods. They did also lower their smoking rates, to their credit. That's always a factor. Amazing study. It wasn't a randomized study. It was a citywide cultural study of teaching people recipes and the rest. How else do we know we might be able to reverse heart disease? Well, there's actually been studies, and you're familiar, but we always have to talk about the plan that a very young medical student, Dr. Dean Ornish, born in Dallas, Texas, for a long time living in the suburbs of San Francisco, designed to ask the question, it wasn't known at the time, if we eat a very low-fat plant-based diet, and we exercise and we quit smoking and we lower our stress through group support and meditation and yoga, can we shrink plaque in heart arteries? And rather than guess, he did a study using heart catheterization because they didn't have artificial intelligence CT angiography back then. Nobody did. But he didn't do just any old heart catheterization. He did use a computer program in Houston to measure it more carefully than is done with patients nowadays, even though this is 1990 data, 1998 data. And this little graph should be hanging in the waiting room of every cardiology office because the black circles are baseline 1 year and 5 years. How much narrowing is in the arteries of volunteers in the study who did not change their lifestyle? And the white boxes are the results of the narrowing in arteries of people who did change their diet and their lifestyle, the treatment group. And you can see in the control group, blockage got worse and worse, particularly at 5 years. And in the treatment group, it actually totally changed the course and started getting better and better. And this kind of difference, even at 1 year, makes a huge difference in blood flow. People are going to feel better. People are going to pass their stress tests. People are going to avoid going to the emergency room, all of which was shown in this study. Of course, many of you recognize this picture from the book Reversing Heart Disease by Dr. Caldwell Esselstyn, MD from the Cleveland Clinic, a seriously narrowed artery in 1996, restored to beautiful dimensions with a whole food plant-based diet in 1999. There's no stent, there's no balloon, there's no bypass. Wonderful, wonderful demonstration. Dr. Ornish has similar pictures, but they're in his original publication. So it should be that as of the mid-90s, the late 90s, game over. We've proven that we can reverse heart disease with relatively low-cost lifestyle programs that are well tolerated, and they also happen to lower the risk of diabetes, obesity, and cancer, but yet it took a long time for this to work its way into the American medical system. So that was the 1990s. This was an announcement in 2010 that Medicare decided to pay to educate people who had had a heart attack, a bypass, a balloon, or a stent about the Ornish results, about the results of a famous engineer, Nathan Pritikin, in the Pritikin Longevity Center. And they were going to pay for a program called intensive cardiac rehab, but you had to already have had that heart attack, that stent, or that bypass. Unfortunately, we'd like to move the needle earlier. How about we find disease on a AI coronary CT angiogram and we get insurance approval? There's only one exception where they'll get insurance approval. If somebody's having angina chest pain that's stable, then the insurance companies will pay to teach patients how to treat their heart disease naturally and low cost with a diet and exercise and recipes and meditation and the rest. So I have patients that do that. Unfortunately, 2010 is 14 years ago, and there are still way too few programs at hospitals that are called the Ornish Rehab Program and the Pritikin Rehab Program. As of now, there is no Esselstyn insurance approved program or Furman approved program, although those are amazing programs. So the key on this slide is the yellow line. There's a little baby up to the left that's got clean arteries, and there's a person with clinical disease in the lower right that has clogged arteries. And we used to say it's hard to see it, but it's a dark black arrow. It just got worse and worse and worse. And now I had to add a yellow line because we can take the soft plaque, which we can measure, and we can reverse it. We can kick soft plaque in the butt. And we need to do it, and we can do it by measuring it, putting in a program, and then remeasuring it, as I've shown you examples. Okay? As we get towards the end, we do agree on a lot. There's food wars everywhere. I've debated all over the place with people. Dr. Dean Ornish was famous for debating people. Dr. Garth Davis has been famous for debating people. But we actually agreed a lot. This is the food plate as suggested by the Physician Committee Responsible Medicine, PCRM. This has been out for over a decade, a beautiful example of eating vegetables and fruits, grains, and legumes. But this is not a plant-based doctor like Dr. Neil Barnard. This is the Harvard School of Public Health. And this is 2011. And what it says on the plate is eat a big heap of vegetables every day, a little smaller but healthy number of fruits every day, whole grains every day, and healthy proteins, which can include nuts and beans as your protein source every day. Drink water, not soda pop. Drink water, not milk. And the Harvard School of Public Health favors olive oil over butters and lard and ghee. You may follow that dictum, you may not. This is this is the Canadian food plate after a big research project. Lots of fruits and vegetables, whole grains, water, not milk, water, not soda, and protein foods. And I sure like seeing some beans and chickpeas, and I see some almonds. I would certainly want to put some walnuts in there. I see that. And I see tofu, and those are the, quote unquote protein foods, but I see protein everywhere here. So that's a misnomer, as we know. One more way to, kick disease in general in the rear is what I call in my clinic the new executive physical, which is considering and learning about those artificial intelligence coronary CT angiograms. You can arrange to do that in any city in the United States if you have somebody to guide you. But there also are advances in early cancer detection. You can get blood work called a Gallery blood test that can detect cancer early. People are paying to get an MRI of their body to detect cancer early. I did that in February of this year, a center in Miami called Ezra.com, EZRA.com. Consider a DEXA scan to evaluate your body fat and your bone density. Maybe get checked for your heavy metal burden and your genetic makeup. Maybe do an MRI of your brain to see if it's shrinking as a predictor of future dementia, and put in a more brain-friendly food program, fitness program, and other approaches. Take great care of your teeth. Make sure you own a home blood pressure cuff and use it. And if you have any problems with sleep, do a home sleep study. They are so simple nowadays. All right, so I am going to stop sharing, and I am going to turn it back to our wonderful host. I think that was Michael, and see about any questions that there may be, and I'm happy to try and answer them, okay? Let's see.
Yes, thank you so much. So thank you for that. We're going to begin the Q&A session or portion of our presentation. And for any audience members that would like to ask a question, please raise your hand in chat, and excuse me, in Zoom. The instructions for how to do so are in the chat. So we already have a couple of people raising their hands, so I'm going to go straight to the audience real quickly. Bear with me 1 second here. Did you guys just hear me? Because I thought I unmuted myself and it said something of...
I heard you.
Okay. All right. Good, good. So we're going to start off with Rita. Rita, go ahead and state where you're from and ask your question.
Good morning. This is Rita Batija from Long Island, New York. Thank you very much, Dr. Kahn, for powerful presentation. I have two questions. How often coronary calcium score should be done? At what point that your calcium score is high? And second thing, Dr. Mark Houston has been mentioning about cardiolipid as far as biotech research to bring down 10% or 20% of LPA little a. So if you have heard about it. but
Yeah.
mainly interested in the coronary calcium scale. And also, if somebody's, LDL levels are high, what about this arterios, I forgot the name that they are talking about. Should one be taking that?
Yeah. Okay, two good questions. I can tell you what I do because some of these things haven't been researched. If I have a patient that has a calcium score of 0, which again is me, I will repeat the calcium scan, $99, about every 5 years and see if they're staying as 0. Some of them I don't institute any treatment other than diet and exercise. Some people with crazy, of course, blood pressure, blood sugar, blood cholesterol will still work on that, even though the calcium score is 0. If I have a patient that has a calcium score of 200 or 300, I don't repeat it because the only thing that happens is it goes up and it doesn't tell me how narrow the arteries are and it doesn't tell me how much soft non-calcified plaque. So I will have a discussion with the patient with a high calcium score about going on to the more advanced test, the artificial intelligence coronary CT angiogram. And let's learn the answer to two questions. How narrowed are your arteries and how much soft non-calcified plaque? I had two patients yesterday morning that I reviewed their artificial intelligence coronary CT angiogram back to back. One was a 65-year-old man whose calcium score was 400, and his artificial intelligence coronary CT angiogram, 80% of the plaque in his arteries was soft, non-calcified plaque, invisible on the calcium score. A lot. He had a lot of plaque. He had a lot of blockage. Never would have known it without that test. And we instituted a war on his heart disease, very aggressive approach. The other was a 58-year-old woman, never would have suspected any heart disease. And she, in fact, had a calcium score of only 14. But because of her very high lipoprotein A level and a very scary family history, she wanted that advanced CT scan, artificial intelligence coronary CT angiogram. And she had about 50% of the plaque in her artery was soft, non-calcified plaque. And we instituted a war on her heart disease, a little less aggressive. And some people, it's less than 50% is soft non-calcified plaque. But I don't repeat a high calcium score. There are other doctors that do. I don't think you learn anything because the number goes up. I tell my patients right from the get-go, I can help you with your heart, but I'm not going to make your calcium score go down because there is no proven way to do that. When Dr. Houston, who is a friend and a mentor of mine, talks about that particular agent from a vitamin company, the reality is lipoprotein A varies 20% up and down. That's published data. If you check a person once a week for 12 weeks, it bounces around. It doesn't bounce, 80%, but 20%. So if a supplement drops lipoprotein A 10 or 20%, you'd have no way to know that isn't just natural variation. And studies show the goal is going to have to be to lower lipoprotein A maybe 80%. And the drugs that the pharmaceutical agencies and companies are working on, I have patients that had a lipoprotein A level of 400, and now it's 10 because they're in research studies with these new drugs. They're not supposed to know it's 10. It's supposed to be blinded data, but they're sneaky little patients and they go get their blood tested and they have a little party. I'm getting the real drug. I'm not getting the placebo. So 400 to 10 is, a 98% drop in lipoprotein A. If that proves to be safe, that should be a very powerful effect. The only thing out there that's even close is some people will take over-the-counter niacin, a vitamin B3. And I have many patients that have lowered their lipoprotein A about 75%. That's a big drop, 400 to 100. But that's still not like these ongoing research drugs are showing.
Great.
So
Thank you.
at what point would you continue to keep taking the Endocalix or the Vascanox
None of them have any data for reducing plaque. So take them if you want. These are just names of supplements that are very expensive. But ask the question, where is the data that they shrink soft plaque and reduce narrowing in heart arteries? There is no data. They may be working, but there's no data. It's expensive to do the studies. So you just got to work with the person you're working with to see if you're going to use those or not. I'm not saying don't use them. I'm just saying don't believe false promises that they've been shown to reduce heart plaque.